Swayam Prabha. Digital India. Educated India.
Hello and welcome. I am Dr. Medora D'Souza Dias from Goa Medical College, and I am going to be taking a clinical anatomy lecture on osteoarthritis and total knee replacement. Our objectives for today's lecture: at the end of this lecture, a student should be able to define osteoarthritis, understand the anatomical basis of osteoarthritis, understand the anatomical basis of total knee replacement, and correlate anatomical knowledge with a given clinical case. Our lecture will be broken up into an outline of segments 1 to 5, segment 1 being a case study, segment 2 gross anatomy of the knee joint, segment 3 we will study clinical features of osteoarthritis and total knee replacement. Segment 4 we will discuss the clinical case, and in segment 5 we will summarize. John N. Insull in 1974, he is an English orthopedic surgeon known as the father of total knee replacement because he developed the total condylar knee. Let's start with segment 1 being a case study. So we have a patient presenting, a 60-year-old obese man presents to the clinic with pain, swelling and restricted movements in both his knee joints. He also gives history of inability to squat in the Indian toilet. On physical examination, the doctor found painful joints, restricted movements of the affected joints and deformity of affected joints. On palpation, the findings were bony thickenings, impaired movements of the joints, and the movement was accompanied by a palpable, sometimes even audible crepitation or vibration. Joint deformity was also palpated. An anteroposterior radiograph and lateral radiograph of the knee joint showed diminution or decrease in the cartilage space. There were osteophytes also found at the bony margins, and sometimes subchondral sclerosis or even cysts were found. Let's now progress to segment 2, gross anatomy of the knee joint. We're just going to recap what you have already learnt previously in our general anatomy lectures. So, knee joint is the largest and the most superficial joint in the body. It's a modified type of hinge joint, and it's in a broad classification of synovial joints. The articulations that you can see here in this picture, so the femoral condyles articulate with the tibial condyles as well as the femur articulates with patella. Please remember that the fibula has no part in knee joint at all. It is not involved in the knee joint. So it's just the medial and lateral condyles of the femur with the patella anteriorly and the medial and lateral condyles of the tibia inferiorly. As I said, there are two femorotibial articulations. So the left and right, or the medial and lateral femoral condyles, articulate with the medial and lateral tibial condyles. These are more for weight bearing as a function. And there is an intermediate femoro-patella articulation because the action of quadriceps femoris should take place without any tendon wear. So this patella is a sesamoid bone in the quadriceps femoris tendon and prevents friction between the tendon and the articular surface of the femoral condyles. Knee joint is a weak joint because the articular surfaces are incongruent. So the two femoral condyles have smooth surfaces and they resemble two balls, and the tibial plateau is irregularly shaped. So this is a warped tabletop. So we imagine two smooth balls sitting on a warped tabletop. Definitely it's not going to be stable. So, what are the factors which maintain stability of this knee joint? So, there are two main factors that you can see here. The strength and actions of surrounding muscles, very importantly the quadriceps femoris, which is made up of four parts. Quad meaning four parts. So, which are those? The rectus femoris, the vastus medialis, vastus lateralis and vastus intermedius. If you recall, these are the four parts of quadriceps femoris. So, the strength of this muscle, especially the vastus medialis, is very important for maintaining the stability of the knee joint. Another very important factor is all the ligaments that connect the femur to the tibia and as well as patella. Let's look at the bony surfaces of articulation. First we look at the patella. So here you can see this is the left patella posterior surface which is articulating with the inverted U-shaped femoral condylar surface. So you have a superior aspect and an inferior aspect. This is medial and this is lateral. So there is a vertical ridge here. This part articulates with the medial part of the femoral condyle and this part articulates with the lateral part of the femoral condyle. Please remember, we are talking about the left patella. If we look further at this surface, there are two faint transverse lines which I have depicted here by two blue marginal lines. Can you see them? So now this divides the articular surfaces into a superior part, a middle part and an inferior part. So when the patella articulates with the femur, it is different depending on the stages of flexion or extension. So in full flexion, the medial most part here and the superior facet of patella are in contact with the femoral surface. In mid flexion, it's very easy to remember, the middle facet is in contact with the femoral condyles. In extension, it is only the inferior facet which is in contact with the femoral condyles. So, the articulation of patella with the femur depends on which stage of flexion extension you are talking about. Let's take a look at the tibial plateau. So, this is the superior surface of the left tibia. This is the medial surface, condylar surface, and this is the lateral condylar surface. So, the tibial plateau is also called the proximal tibial surface, having medial and lateral articular surfaces which correspond in articulating with the medial and lateral condyles of the femur. The medial articular surface, can you see, it is oval compared to the most circular lateral articulating surface, and it is longer than the lateral articulating surface. If you look at the femoral inferior articular surface, they are convex condyles. So this is the left femur, the medial condyle and the lateral condyle. Here you can see the medial condyle is longer. So this is in congruence with the medial articular tibial surface being antero-posteriorly longer. Please remember that the articular surfaces of tibia and femur are covered by a plate of articular cartilage to maintain a smooth articular surface for the knee joint. Now this femoral tibial joint is special and we say modified hinge. There are cartilaginous C-shaped plates which are called menisci, which lie between the articulations of the femoral condyles that you can see here and the tibial articular surfaces. These menisci are cartilaginous, as I said. They are made up of hyaline cartilage and they accommodate changes in the shape of the articular surface during joint movements. they provide a cushion-like surface and congruence. So what happens is, if you look here, this is an extension and this is in flexion. In extension, the femoral condyles have a flatter shape, but in flexion, the femoral condyles have a more curved shape. And so these menisci accommodate for the changes in shape of the femoral articulating surfaces between different stages of flexion and extension. Let's look at another diagram now. Here we have depicted the knee joint, but you're looking at only the tibial surface, and this is the patella ligamentum patellae, a part of the quadriceps tendon, and these blue C-shaped structures are the menisci. So this is the fibula here, doesn't take part in the knee joint. So this is the lateral meniscus and this will be the medial meniscus. So both of them are C-shaped, they are intracapsular, they are fibrocartilaginous. What do? Is they provide congruence by widening and deepening the tibial articular surfaces, and they allow the femoral condyles to articulate with this deepened condylar surface. If we summarize the functions of the menisci, they spread the load because knee joint is a weight-bearing joint. It carries the weight of the entire body on the two knee joints. So they spread the load evenly along these cartilages. It increases the congruity, as I have already mentioned. It provides a smooth articular surface to the irregular tibial plateau. It provides stability and it cushions the underlying bone from the forces of movement. So these are the very important functions of the menisci. Now, which are the ligaments of this knee joint? Just to summarize, we are not going to go into much of detail. So the patella ligament is one important ligament. That is the degenerated tendon of the quadriceps femoris. It attaches the inferior end of the patella to the tibial tuberosity, and it's one factor for maintaining stability of the knee joint. Then there are the collateral ligaments. So here you can see this is the fibular collateral ligament attaching the lateral condyle of femur to the fibula, and on the opposite side you will get, on this side, the medial side, you will get the tibial collateral ligament, which attaches the medial condyle of femur to the medial side of the condyle of tibia. Besides these collateral ligaments, there are cruciate ligaments. Why are they called so? Because they are like a cruciform shape. So this is the anterior cruciate ligament. It's named so because it is attached to the intercondylar area of tibia anteriorly. And there is a posterior cruciate ligament because it is attached to the posterior part of the intercondylar area of the tibia. Besides this, anteriorly intra-articularly, there is another ligament called transverse ligament. So these ligaments, the patella ligament, the fibular collateral ligament, the tibial collateral ligament, the anterior cruciate ligament, posterior cruciate ligament and transverse ligament are all maintaining stability of the knee joint. What about movements of the knee joint? So, knee joint has primarily flexion and extension. So, we said it is a hinge joint, but we also said modified hinge joint. So, in extension, this is what it looks like. The angle, or rather the axis of flexion extension, passes transversely through the two femoral condyles. In flexion, there is a bending of the knee, there is a gliding and a rolling movement that takes place of the femoral condyles upon the tibial plateau. Besides flexion and extension, there is a locking mechanism. Now what happens is, during full extension, the muscles which are for extension, like the quadriceps femoris, are contracting. Now in long standing positions, we cannot expect the quadriceps femoris to keep on contracting. So there is a mechanism called a locking mechanism which locks the knee joint in a close packed position around a vertical axis, and the femoral condyles, they rotate medially over the tibia and make it a close packed position, which is important for long standing to prevent strain on the extension muscles like quadriceps femoris. So locking is brought about by the vastus medialis of the quadriceps femoris, and when flexion wants to take place, locking has to unlock. So unlocking is opposite, which is lateral rotation of femur on the tibia when the foot is on the ground. That is brought about by popliteus muscle. So because of this locking unlocking mechanism, the hinge joint it's a modified hinge joint. So we say the knee joint is a modified hinge joint. What are its movements? Primarily flexion extension, but also a locking and unlocking mechanism that takes place. So the stability of the knee joint is the muscles which are surrounding it, primarily the quadriceps muscles as well as the ligaments which we already have said. We have named all the ligaments which are supporting the knee joint, and we have also to mention that there is a fibrous capsule which also supports this knee joint. Now that we have completed a brief anatomical description, let's move on to the important part. Osteoarthritis of the knee joint. So this is segment 3. It's the most common disease of a joint and it's a degenerative type of disease. It is due to abnormal forces across the joint with normal cartilage, or it could be due to normal forces across the joint when there is abnormal cartilage. Now it is degenerative, means what? Due to wear and tear. So normally any joint has got wear and tear, but usually any joint has a capacity of the articular cartilage to repair and renew itself. So if the wear and tear is less than the renewal capacity, the joint remains normal. But if the wear and tear exceeds the joint capacity of renewal and repair, then you will get degenerative joint disease due to this wear and tear process being too much. What are the etiological factors for osteoarthritis of the knee? The first one we say here is congenital failure of normal development. So there is some deformity congenitally or some defect which predisposes, or a history of a previous fracture or trauma or injury to the knee can predispose. A derangement internally, for example, pieces of cartilage, they separate out and they become loose bodies, or a torn meniscus due to an injury becomes a loose body within the joint cavity of the knee. Then any previous disease which is leaving any damaged articular cartilage, or malalignment of the bones, say there is a bowed leg or genu varum, or knocked knees or genu valgum deformity, causes malalignment and predisposes the patient to osteoarthritis. Obesity is an important factor. In fact, the patient who comes to the OPD with this has obesity. Because of increased weight, then the stresses on the joint become more and there is more wear and tear of the cartilage. Sometimes there is a genetic predisposition. So you will see this osteoarthritis running in the family. And increasing age is another factor, because increasing age means more wear and tear of the articular surfaces. So what is the case history? So the complaint will be informed to the doctor along with whatever the patient is feeling, like pain, swelling of the joint, movement becomes less, pain on movement, some kind of vibration felt in the joint. And the doctor will also review the patient's lifestyle. Does he have a sedentary lifestyle? Is he a sports person? Is he having active field work? So the doctor will check the level of activity of the patient. The history that the patient gives is a clue to the type of injury and likely findings on clinical examination. Like the patient might say he was a sports person in the past, or he played a sport with high stress activity like basketball on a hard court or tennis on a hard court. So this history gives you a clue that possibly the stresses are more on this joint as a sports person and have led to more of wear and tear. So here is the patient's knee, his left knee. Patient presents of having an age above 50 years. Usually, in the female group, we find that the patient is usually elderly and even obese, and mostly both the knees are affected or both the sides are affected. Whereas in the male group, the person need not be elderly, but he usually gives a history of a previous injury or some type of sports injury in the past. So what are the clinical features that the patient presents with? First, pain and swelling. So this pain and swelling is gradual. It doesn't suddenly start. It gradually occurs over months and even years. So there's a gradual increase in the amount of pain. There's a gradual appearance of the swelling which keep increasing over months and years. This pain usually becomes more on rising from the bed or at the end of a day's activity. The second clinical feature is restricted movements of the joint. Inability to straighten the knee joint fully, less type of movement or interfered with movement. Movement is not smooth flowing. Then stiffness of the joint is another complaint. It's caused, one, because usually there is pain. So the person is scared to move the joint too much, and also there is reflex spasm of the surrounding muscles which causes the stiffness. In the end, the deformity starts. So initially it is produced because of the muscle spasm, but later on it is because of contractures of the muscles. So you will get either genu valgum, genu varum, because of the deformity that is taking place, and this deformity takes years to happen. So the doctor will next do an inspection of the joints which are affected. You will notice that the joint will be swollen, there is wasting of the quadriceps femoris muscle, the genu varum deformity will be seen in later cases. On palpation, when you feel the joint margins, you will feel osteophytes or extensions. Now in this picture here, can you see these osteophytes? I have labeled them here. You can see it's like a lipping or an extension of the bony margins. Even on this side, you can see the osteophytic areas. Okay, so you get these osteophytes. The bone contours change, there is thickening of the margins and you get these osteophytes. There is local tenderness in the joint line over the attachment of the medial ligament also. Then there are some tests like the fluctuation test. The basis of this test is when there is osteoarthritis, there is increased joint effusion, meaning the fluid, the synovial fluid in the joint becomes excessively more. So how will you test for feeling this excessive fluid? So one of the hands of the examiner is going to compress the suprapatellar bursa. When you compress the suprapatellar bursa, what happens is the joint moves downwards and then it impulses laterally and medially. So with the fingers of the other hand and the thumb of the other hand, the examiner is going to feel for that fluid impulse. So this will show you a positive joint effusion in the knee joint. The other test for joint effusion is called the patellar tap test. Here you see the examiner's fingers. So again he is pressing the suprapatellar bursa and he is tapping the patella inwards so that it hits the femur condyles. So when the patella hits the femoral condyles, you will feel the resistance of the joint effusion fluid, and through the resistance the patella is going to take more effort to touch the femoral bony surface. So these are the fluctuation test and the patellar tap test. They are both tests to confirm a joint effusion in osteoarthritis of the knee joint. Then when you are examining the patient, you also have to test for movements. What type of movements? Active as well as passive. So active would mean telling the patient to perform the movement, and a passive movement would mean that you are moving the limb without effort from the patient. So you will find that the movement of the joints is restricted there is pain on movements. The patient will complain that his joint is paining when you are passively moving it. You will feel the vibrations and crepitations on the movement, and one important fact is you will find that the patient is not able to straighten his knee fully. Even passively, if you try to straighten his knee fully, it will not be possible, or he will complain of severe pain. So these are what you find when you are trying to do the movement tests for the joint with osteoarthritis. Then you will also have to take an X-ray. The X-ray will always be in two views, an antero-posterior view as you can see in the first one here. This is antero-posterior view of the knee joint of the left side. So this shows you APL, antero-posterior view of the left knee joint. What can you see? Can you see the space here now? This is the joint space where would lie the menisci and the synovial fluid and the synovial membrane. So can you see on this medial side, the joint space has been diminished quite severely. This is one. Secondly, can you see the lipping of the margins? Even here you can see slight lipping. So these are the osteophytic extensions of the margins of the joint. So these are two very visible features on taking an X-ray. This confirms your osteoarthritis of this joint. Now this is an X-ray taken in standing position as is mentioned here, and the same joint is seen on a lateral view. Here also you can see there is a reduction in the joint space, and then you are looking for osteophytic extensions. Okay, on the patella you can see osteophytic extensions on a lateral view. Sometimes you can even see something called subchondral sclerosis, which is not really evident in this X-ray. How will you treat this osteoarthritis? Now the treatment depends on the severity. So either you will do no treatment, you will only advise the patient, maybe change his lifestyle or reduce his weight, okay, to take away the obesity factor. You will reassure the patient. Or you might say the patient needs conservative treatment, maybe some mild form of analgesia drugs and physiotherapy. Operative treatment is kept as a last resort for severe cases. So we'll explain now. So when there is no treatment, you are just reassuring the patient, you are altering the lifestyle. So if the patient is sedentary in his job, you will tell the patient to take a walk in between, or he should walk at least maybe half an hour a day, a brisk walk. Okay. So advice to restrict excessive stresses on the affected joint. So if the patient is having history of going to a gym or history of lifting weights or doing any stressful activities, too much of climbing of stairs can also be a stressful activity in obesity. Very important is the second thing which I have written here, which is weight reduction. Very, very important, because the moment there is weight reduction, automatically the stresses on the joint become much less. Then when you say conservative treatment, what is it? One is physiotherapy, local heat, or they give the patient exercises to strengthen the quadriceps muscles like sandbag exercises or just contracting the muscle while lying down in bed. Then there can be symptomatic treatment with analgesic drugs. Say there is pain, you will give analgesic drugs to reduce the pain, or you will give cartilage supplements of chondroitin. You can even do supportive bandaging of the joint and reduce the stress on the joint, like reduce the walking or ask the patient to take support while walking with a cane or a crutch. Operative treatment is in very severe cases. Now, what are severe cases? If there is pain at rest, say the patient is sleeping in the night and he gets too much of joint pain that he is not able to sleep, so that would come to a severe case. Or there is a limitation of function, so the daily activities of the patient cannot be performed because of his osteoarthritis. So then you will treat this as a severe case and you will recommend some type of active therapy or operative treatment. So there are here now, I have written 4 different forms of active surgical therapy. First is arthroscopy. For example, the patient is having torn meniscus or is having some pieces of cartilage as loose bodies floating in his joint and creating the osteoarthritis. You will remove those bodies using arthroscopic procedure. Or you will do osteotomy and realign the joint surfaces. One very commonly used method is arthroplasty, which you may have heard of, wherein the entire joint is constructed newly by artificial prosthesis. And arthrodesis was earlier done, wherein there is elimination of the joint by fusion. So they fuse the knee joint and you can no longer move by flexion. It becomes straight in one position itself, usually kept in extension. So today's topic is more about arthroplasty. So we'll proceed with different types of knee replacement. So what is knee replacement? Knee replacement is called replacement arthroplasty of the knee. It is defined as being a total replacement of the knee joint by creating an artificial knee consisting of metal components and plastic components at the femoral and tibial ends and removal of the defective bony areas. So what they do is, if there is osteoarthritis of the knee joint, they remove the defective bone area and they replace it by putting a metal prosthesis and a plastic component in between. The results are good in more than 90% of patients because this kind of therapy, it's surgical, but it relieves the pain of the patient, it corrects the deformity of the knee joint, and it most importantly restores mobility. So the patient can go back to his lifestyle, he can go back to his work, he can have a life which is fully functional just after replacing the knee joint with an artificial prosthesis. But there are complications, like there could be infection, osteomyelitis, or failure of the prosthesis. It can fail in short term or it can even fail after many years. So there is a life of this prosthesis. It depends on how it is used and how it is also fused. Okay, the success of the surgery and the success short term and long term depend on many factors. So there's a combination of plastic and metal prosthesis. It makes the smoothness of cartilage on cartilage. Now the results are good in low demand people who have more of a sedentary lifestyle. But if they are like, for example, sports persons or people who have a high activity lifestyle, they are not sedimentary, then what happens is the bone can break down where there is a junction of the prosthesis and the bone, and the prosthesis can become loose and then the prosthesis can fail. So you'll have to redo the surgery and put a new prosthesis. Today, with improvements in bioengineering and surgical techniques, the prostheses have improved in their quality and it has been providing better results. And so the failure of a prosthesis now is less than it used to be before. Now what types of prosthesis can be used? In this figure you see, this is a prosthesis involving only one side femoral condyle and one side tibial condyle. So this is called a unicondylar knee replacement arthroplasty. Now post-operatively, the range of motion is not like it could have been in a normal knee pre-operative. So the post-operative range of motion is usually 105 to 125 degrees of flexion or 0 to minus 10 degrees of extension. The other type of knee replacement is both the condyles. So this is called a condylar knee replacement arthroplasty. There is an upper metal component, there is a lower metal component, and in between there is a plate of plastic component. Again, the range of motion is the same, 105 to 125 for flexion and 0 to minus 10 for extension. Now here is an X-ray, an anteroposterior radiograph of a patient where both condylar knee replacements have been done. Bilateral, you can see right and left. You can see the femoral prosthesis and this is the tibial prosthesis. The crepe bandages are still on the patient and you can even see the staples. Can you see them? So these are the crepe bandages and these are the two prostheses of both sides. Let's come to the clinical case discussion. So our first question, what is your diagnosis and why is it so? So we are making a diagnosis today of osteoarthritis of the knee joint. And why are we making this diagnosis? Because of looking at the classical signs, the patient's history of pain, inability of movement, stiff joints, inflammation, and this progressing over months and even years, ultimately ending up with joint deformity like bowed legs, bowed knees. Then what are the classical signs in this case? As I said, the history of the patient, which I already have described, and then the findings of the doctor, like on examination, what will he find? He will find the movements are painful. He will on inspection see that the joints are swollen, they are inflamed, there is deformity. On palpation, he will find that there is crepitus on movement, again there is pain, stiffness of the joint, inability to extend the knee joint till it is straight, and the patient will complain of pain while moving it. He can do the fluctuation test and the patella tap test for joint effusion, and he can take an X-ray also. On an X-ray he will see diminution of joint space, osteophytes will be seen at the bony margins, so he can make a clinical diagnosis of osteoarthritis of the knee joints. So radiological findings, as I said, osteophytes can be seen, diminution of joint space and deformity of the joint like the genu varum. Then the last question is, what are the types of knee joint arthroplasty? As I described, they could be unicondylar arthroplasty or condylar arthroplasty. In unicondylar, it is done only on one condyle, tibial as well as femoral, and it is made up of a metal component on either side, and in between there is a plastic component. Well, the condylar type is we are involving both the condyles of tibia with both the condyles of femur which are replaced. To summarize today's lecture, so we have spoken about the anatomy of the knee joint because we wanted to describe osteoarthritis and knee joint replacement. So osteoarthritis, we said it is a degenerative joint disease. There's a wear and tear process which exceeds the joint's ability to repair and renew itself. Then on clinical examination, the features being pain and swelling in the joint, there are restricted joint movements, there is stiffness, and last is deformity like bowed knees. On inspection, there is a swelling of the joint, wasting of quadriceps femoris muscle, a genu varum, deformity. On palpation, you can feel the bony contours, margins have osteophytes, there's thickening at the margins of bone, there's local tenderness, over attachment especially of the medial ligament, and fluctuation tests and patella tap tests can be done for increased joint effusions. On movements, active movements and passive movements are both checked. There is restriction of movement, there's pain, crepitations and ability to strengthen the knee fully. Then on taking an X-ray, the radiological findings include decreased joint space, subchondral sclerosis, spurring or lipping of the joint margins. That means you know that the patient is now having osteophytes, and you might even see the joint deformity of genu varum. Then we spoke about replacement arthroplasty of the knee. So it's a total replacement of the knee joint by an artificial prosthesis composed of metal and plastic components. We could either do a unicondylar, that means one condyle of femur and tibia, or bicondylar, where you are doing both the condyles of femur and tibia on one side or one knee of the patient. So with that, we end with today's lecture. I hope you have understood. Thank you very much.